Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. This post is the first of 3 installations in the program Optimizing Outcomes in Older Patients with HBV. During this podcast, Dr. Nancy Reau, Professor of Medicine at Rush University Medical Center in Chicago, defines what older means when considering older adults with HBV and discusses strategies and considerations for managing an older patient with chronic HBV who is visiting the U.S. from sub-Saharan Africa. For more information about Dr. Reau and for a link to the full online educational program, please visit the link in the show notes for this episode. Now, let's get started and hear what Dr. Reau has to say about caring for older patients with chronic hepatitis B, illustrated through a case.
I want to thank everyone for joining on this program discussing hepatitis B in older patients. I'd like to put this into the context of an individual that was in clinic not that long ago. I had a young woman who is from sub-Saharan Africa who came in with her brother. Her brother lives in the United States and is a faculty member at one of the near universities, and she was visiting, and he has hepatitis B, and he was talking to her about her disease, and she had not seen a clinician for a while because she had been told that she had inactive hepatitis B, and it had been monitored for a little bit, and then she just didn't, have any more monitoring. Our patient was about 40. And so when we think about how we identify individuals with hepatitis B that are higher risk for some things like liver cancer screening, women are not really considered high risk until the age of 50. But when we're defining an older patient with hepatitis B, it's not just in the context of cancer risk. And we recognize that the longer a person has chronic hepatitis B, the more likely they are to develop more advanced liver disease. That's partly because fibrosis pathways change as we age. It's also because some of our patients have had intermittently active disease, like little bouts of flare, or they have had persistently active disease. And that has resulted in more inflammation and more scar tissue. And that's obviously going to progress gradually until it's more clinically apparent. And so when we're defining someone who's older, our guidelines really start to talk about that definition around 35 to 45 so that there isn't complete consensus. But certainly by the time you're in your 40s, you are an older person with hepatitis B, not geriatric, but older. And in some of our guidelines, they push that metric down into the mid and late 30s. So our patient definitely hit the threshold of being an older individual. And because when you're told that something is inactive and that you don't need to, that it's monitored for a period of time, you still don't need therapy, and everyone makes it feel like it's relatively inconsequential. She really hadn't thought much about her hepatitis B until she was visiting, and her brother is on therapy. So he was pushing her to kind of have things updated. And so they got her into clinic while she was visiting, and we repeated her labs and did a fiber scan. So you could see how she was defined as inactive. Her ALT and her AST were absolutely normal. Normal is defined differently. So sometimes our labs give all kinds of variable definitions for normal. But by AASLD guidelines, an ALT of greater than 25 for a woman or greater than 35 for a man is clearly abnormal. And her values were in the teens. I think they were like 15 and 16. So she had, by all definitions, normal ALT and AST. But her viral load, she was E antibody positive, which is not unusual. Her viral load, however, was just a little bit above 2,000 international units. So not terribly high, but on the lower end, and above that 2,000 international unit threshold that we might start to try to define an inactive carrier. And even that, I think the definition of inactive carrier or someone who doesn't have clinical disease is probably evolving. But so she fell into kind of the gray zone. The DNA was higher than guidelines would recommend, so high enough that you should start to consider treatment, but her ALT and her AST were normal. And when I went back and I looked at her records that she had brought with her from home, her DNA was persistently in that 2,000 to 200,000 range. So her hepatitis B DNA was fluctuating and never was undetectable. Her liver enzymes were, for the most part, clearly normal. So she was one of those individuals that was in the gray zone, and no liver cancer in the family, no cirrhosis in the family. but the family did have a fair amount of hepatitis B. And there was some early deaths for other reasons. And so it's possible we could have missed signals simply because the individuals that had hepatitis B hadn't lived long enough. But her brother was on antiviral therapy because he had had a more active disease, and he wanted her to consider antiviral treatment. So when we're thinking about this patient and discussing with this individual the advantages of treatment or no treatment, of how to monitor this is really important to overlay with your chronologic age. And so our patient has now fell into a time period where her risk of developing disease, whether it's more progressive fibrosis or whether it's liver cancer risk, increases. She also falls into a time period where, as a person, you're more likely to develop comorbid conditions like diabetes, obesity, metabolic syndrome, maybe more likely to have some stressors that lead to unhealthy alcohol use. Our patient was not overweight, did not have diabetes, and was not a heavy drinker. But these factors all push us to probably look at our patient slightly differently. And when we look at epidemiologic data, we do recognize that this group of individuals that has active viral replication, surface antigen positive, is at risk for liver cancer. It's not perfectly clear that treating this gray population that doesn't fall within well-defined guidelines for treatment decreases their risk of progression or their liver cancer rates. But when we extrapolate that to natural history data and some of the smaller studies that have looked at treating patients like this, there is the sense that you could risk reduce this individual if you engage them in treatment. So the thing that we haven't discussed is the FibroScan. So we did a FibroScan. She did not have significant steatosis. She's sub-Saharan, she's Black, so she is less likely to have steatosis anyway. But her fibrosis marker came back at 7.2 kilopascal. It was a good study. So that is not high risk for advanced fibrosis, but it's not perfectly normal either. And when we took this into the context of persistently active viral replication, she was interested in starting treatment. And I supported that decision for her because I think that she, given that FibroScan, given the persistent replication, was at risk for progression. And we started her on antiviral therapy, and her virus nicely suppressed over the next 3 months. Now, we did have to transition her care to her family doctors or her clinical care team at home, but her brother promised that he would help to get her records over so that we could kind of virtually spy on her to make sure that she was doing okay. So when we are discussing treatment decisions, so our patient was actually fairly healthy, did not have any problems with renal dysfunction, did not have any problems with osteoporosis or osteopenia. And so I think for our patient, you want to use any of your approved first-line treatments, which could be entecavir or tenofovir in the form of TDF or TAF, because she was at lower risk for bone and renal complications. But had she been older, had she been thin, had she had hypertension, diabetes, other factors that impact the bone and renal health, then you probably would have pushed more towards TAF or entecavir. Because I knew that she was going to have some access issues at home, we wanted to use what would be easily accessible in her home. TDF was the easiest agent to get access to. And so for her, we used tenofovir in the form of TDF.
Those are excellent points to consider when evaluating and making a treatment decision for an older patient with hepatitis B, including consideration of medication accessibility. I'd like to thank Dr. Reau for that excellent discussion, and thank you also to our listeners for joining in. As a reminder, to view the full program on optimizing outcomes in older patients with HBV on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.